Right, well, I reckon that makes it 12:30. Good afternoon, everybody. My name's Paul Jones. I'm the Chief Digital Information Officer here at the Trust. It's my honour to be chairing this. Phil sends his apologies. He can't make it today, but I've been lucky enough to get put in his place. We've got three, so we've got quite a lot of stuff to get through in our half hour. So we've got the pharmacy leadership with Tim, we've got psychology with Lauren, and then we've got the midwife team as well. So what I'm not going to do, I'm not going to allow questions in between the three of these, because I think we'll probably end up then getting stuck on the first one and two, and we'll squeeze the last one a little bit too tightly. So if you do have questions, then just store them up, perhaps put them in the chat, and we'll come back to them if we can. And if there is a little bit of time at the end, then I'll open up questions to all three of the presenters today, if that's all right. So lovely. Let's kick off. Tim, are you with us and ready to go?
Hello. Thank you very much. Yes. I've just noticed on my screen it looks like my image is flickering. Is everybody else seeing that as well?
We can hear you fine though.
Okay. What I'll do then, I'll turn my camera off so there's less of a distraction. Thank you. And thanks again for the opportunity to speak to you all today. Hello, my name's Tim. I am a pharmacist by background. I am one of this year's Clinical Leadership Fellows, and I'd like to talk to you for 5 minutes just about Leadership Lab. So I'm sure we're all aware about how critical leadership is, but for some people it can be underappreciated, and if you're not in a leadership role, it can be quite hard to develop your leadership skills. Even if you identify that you want to do that, you might not be aware of what the opportunities are. And if you are aware, then that range can feel a bit limited, that there's very basic things or very advanced things and not much in the middle. We knew from our workforce intelligence that there was a particular need amongst our advanced clinical pharmacists. So this is the career grade amongst pharmacists, so the lead pharmacist for a particular clinical area such as respiratory or neurology. And people tend to spend quite a long time, sort of 10 to 20 years in that job role. And I'm sure pharmacy isn't alone in having lack of development opportunities cited on exit interview as a reason for moving on. But we also recognise that whatever we were offering needed to fit into a busy work schedule. So what did we do? Next slide, please. Thank you. So we had a motivated group of pharmacists, two recent Clinical Leadership Fellow alumni in John Navis and Angela Bergin, myself as a current CLF, and Kirsty Cavell, who's a workforce development pharmacist with a responsibility for pharmacists in the post-foundation period. And we looked at what resources we had. Kirsty had set up an advanced pharmacy development pathway, including a research cafe to try and support that pillar of advanced practice. So we had some resources that we could rely on to use as a template. And we used our learning, particularly from the FLP, to bring things like compassionate leadership and the healthcare leadership model and those kind of principles into the department. Leadership's so diverse, we wanted to offer a range of opportunities, but also to make sure that it was meeting the need of our peers. So they told us things that they needed or were interested in learning about, but we also recognised that there were these unknown unknowns that people just weren't aware of, perhaps. And then we started to think about how we might measure impact. Next slide, please. So the outcome was Leadership Lab, which is tagged as a safe space to learn, experiment and discover. A lab was intentional because if leadership is a relatively new, or you're just taking your first steps into that, sometimes you need to almost play with the ideas and play with the language. And we wanted to create a safe space where people could do that, and where people were able to be vulnerable, to talk about mistakes, to get things wrong, and can I have another go at saying that? So far, we delivered 3 sessions covering the self, followership and systems leadership, and we've another one in 2 weeks. These are recorded, and then any resources that we have are linked to a Padlet, which it links to the advanced development pathway. You can see some of the feedback there, and really in an hour and a half, people aren't going to become amazing leaders, but if it's made them think differently or prompted them to have a conversation or do something, then really that's what we've been trying to achieve. So there were more conversations around leadership happening in the department, but it wasn't just conversations, it was action. Next slide, please. So we took feedback from attendees and asked them what they'd done as a result of attending. So this was, in appraisal season, getting leadership onto their appraisals, putting it on their PDP, seeking leadership conversations with senior leaders in the department, and people saying that I've applied to do Improvement Academy leadership course as a result of this. I wouldn't have done this if it hadn't been for the leadership lab. You can see that each time we've run a lab, the attendance has increased. So people are seeing that it's valuable, it's worthwhile, it's worth dedicating some time to, it's relevant, it's engaging. We've created this effective thinking space where we identified a mentoring need within that cohort of staff. Senior leaders in pharmacy had started to think that maybe they needed a mentoring program, but the culture that we created within Leadership Lab enabled that two-way conversation between senior leaders and staff to say, actually, we're crying out for this mentoring program. So that's accelerated that work stream for staff and for senior leaders. And as a group of pharmacists delivering this, we actually felt empowered to do this autonomously. We knew there was a need. We knew we could meet that need, and we just got on with it. So we had conversations with line managers, but we didn't go through that usual permission seeking and procrastination about what can we talk about, what can't we talk about. We just did it. And then when we subsequently have presented it more formally to senior leaders, brilliant. You've taken the ownership of this and dealt with it yourselves. And actually we support this, but we're not going to direct you how to do it. Okay. And then just lastly, thinking back about what we might have done differently. So there was a bit of an engagement challenge because, Angela has since left pharmacy to start a PhD. John moved on to a different job in the organisation. Kirsty left to get a job at the university, and I'm still on secondment. So there was this we were really critically aware about this being an external thing and it not being owned by the department. So subsequently worked with pharmacists to build the leaders within Leadership Lab as practicing pharmacists as part of the department. So that ownership is there. It's felt we own this, it's ours. There was a bit of a time sort of workload challenge, I'm sure you can imagine, which we'd have senior support at the start. It would have been easier for people to say, actually, I need this on my job plan. But equally, we didn't want to get bogged down in that permission seeking. So there was a balance there. Whilst it would have been easier to carve time out to do this with senior support, it would have delayed us getting it going. Okay. And actually, thinking back now, trying to pull people from outside pharmacy in to give a different perspective, a broader perspective, perhaps on leadership, would be beneficial. So that's certainly something we want to take forward in the future. So thank you very much. That's all I had to say.
Brilliant. Thank you, Tim. I mean, there's so much, loads of round of applause across the group. So much to kind of see and reuse, I think, in other parts of the organisation. And you hit some of my kind of key words around leadership development and people owning it and giving people permission. So that seems a fantastic piece. As is the nature of today, we're going to have to dash on. Lauren, are you ready to kick off?
Yeah, ready.
Thank you.
So, hi everyone, I'm Lauren and I'm the Business Support Manager for Psychology, currently covering the mat leave for the Business Manager. Not all of you will have attended a few weeks ago, but I spoke about the first improvement week that I did it in psychology and it went really, really well. So we decided to put another one in. So just a bit of background on how I approached the week. I did stick to like the RPIW format of a 5-day event. I did on the first day, I took the first day of the teaching, I just adapted it a little bit more for what I kind of knew we'd be looking at, so I could teach them the tools that would really help them to focus on what we were going to look at that week. I used a waste exercise just to get them to all think a little bit differently about some of the waste that may sit within our processes that can make not only the admin's life a bit challenging, but also the clinicians. And then we moved on to a process mapping in the afternoon. Next slide, please. So the first time round, we looked at from when a patient is first referred into our service and up to their first appointment. And then this time round, we looked at once that patient's attended their first appointment, that cashing up stage and the disposal stage. So, did this patient attend? Did they DNA? Did they cancel? And as I'm sure most of you are aware, depending on which one happened, there's many different routes that goes down. And then there's also that next step of what do we do with the disposal side? So do we need to give this patient another appointment? Do we need to add them to a waiting list? Do they need discharging? So I'd say this is probably one of the shortest cycles of process mapping that we did. However, as we were diving into all the different routes that we have for each of the steps, we decided there was plenty for us to focus on in that week, and just to really try and get a standard of how we're all doing it. You know, there's a lot of clinicians, we're split into 3 services, and there's quite a lot of deviation. So next step, please. So we started off as well with some of the myth busting. I think over time, especially throughout like COVID and then trying to get back to normal, there's been quite a few myths that were really quick wins to focus on. So one of them was that in the past, somewhere along, we'd been told that we couldn't have, we thought we'd been told that we couldn't have a green confidential waste bin for confidential notes. So the admin team had been shredding, and the clinicians, all their notes every single time on a massive industrial shredder that we had, which then broke. So we were going to have to obviously replace it, which was going to cost a little bit of pennies. But during the week, this discussion came out, and we rang Estates, I think, or whoever it was, and we are having a green bin delivered to psychology. So no longer does anyone have to do any of that tedious shredding, and we've not had to spend an extreme fortune on a brilliant shredder. And I think it just shows that it's such a little thing, but it can make such a big impact as well. So just having everyone in the room that week, just things started to come out that we could really quick win and fix. The next one was, since COVID, we do have clinicians obviously that will see their patients from home, or patients just prefer to have telephone or video appointments. Our clinicians didn't think that they could have remote set clinic codes, which basically just means that when admin are booking into their appointments, the clinic code itself will say remote, so we know that we're either booking a telephone or a video appointment. Just saves that backwards and forwards of talking to the clinician to ensure that we've made sure that we've booked their appointment correctly. There was also some myths around admin not being able to go on PPM and follow like the process of a pathway, like for a patient, to see where they've come from. So that caused quite a lot of communication, the inbox piling up between admin and clinicians. So that was clarified, and admin showed obviously how they can look at PPM. Next slide, please. We also did some really quick wins with some visual control and 5S. So I don't know if people have heard of what 3 words. I hadn't. I was enlightened of this in the week. So it's basically each like square, maybe not of the world, but it has like a set 3 words. So it's really, it'll take you direct to that place if you put that into your maps. So we went round, I say the royal we, the clinicians went round and got the what 3 words for each of their clinics, so that we can make it a lot more clear for the patients on the website of where they're actually coming to. So because we realised that some patients were not getting that full hour because they were spending their time trying to find some of our locations that are not easy to find. We also have a room down at LGI where there was no seats for the patient to wait. There wasn't any signs, so we got some chairs ordered for the patients just to sit on whilst they wait for their appointment, and we also put some signs up down at LGI. Also in the first week, we started looking at the X drive, which is like our G drive, where we save everything. And this week we continued that. However, we noticed it had just become such a massive job that the easiest way would be to start again and have a new X drive and give everyone till the end of the July to move anything that they think they need, that they use from the old X drive into the new one, and then we're just going to delete what's left, because there was folders and folders upon folders, and quite a lot of people admitted that they don't really use it anymore because it's too hard to find things. So we thought, let's start again, give people the time to get it out and go with a new one. Next slide, please. So this is just like how we shared with the team some of the decisions and the changes that we made during the week. During this week, we focused a lot more on really big decisions in how we changed how we looked at processes. And some of these decisions could feel uncomfortable for clinicians and admin. Some of them are quite big changes, and it's putting that trust back into each other. You know, we've all started working a little bit differently over the pandemic. Certain clinicians started like doing things themselves because it's a little bit easier, or they didn't have access to the admin team. And the team were absolutely amazing. Honestly, you know, I appreciate that some things felt massively uncomfortable. And throughout the week, people who couldn't attend, they rang in, they came to the room, they came and asked loads of questions. We attended huddles, and they just all really embraced the changes. So some of the stuff that we also started to do was declutter all the clinic rooms and try and make them a standard across Fielding House. Little things like making sure that they've all got a working desktop, that there's a clock in all of them, so you can keep an eye to make sure your clinics aren't running over. We also had a process with PPM referrals where we was accepting the referrals on PPM, registering them on PAS, but keeping them on PPM until we'd finished seeing the patient. Somewhere along the way, we've kind of forgot to discharge off PPM just due to busy time frames and maybe people forgetting to do this as part of their leader standard work. So we ended up with probably over 800 referrals that needed discharging from PPM, so we could really start again and see clearly what we've got on our referral list. I can say we're over 50% clear of them now, so we're really working towards getting that more clear and concise. We did a standard how-to guide for PAS. So one of the biggest changes that we're implementing is that all of our clinicians are going to go through PAS training. We've reached out to the PAS team, and they're going to do some bespoke sessions for up to about 15 people, which will just really make it easier for the clinicians to, some of them, you know, really want to book in just there and then with their patient, and just being able to see and understand a little bit more of what happens on PAS. So that will be happening. We're hoping that will all be done by September. We've also brought back to booking in at the desk. So we stopped doing that during COVID, but we've had our visors all taken down now, and we're bringing back that patient interaction of just being able to come up to the desk, choose their appointment and book. So that's really good as well. We agreed that we would bring back in being a bit more stricter, I'd say, with our opt-in and DNA processes. Sometimes we would have to, if a patient cancels, the admin would have to register that on PAS, email the clinician, let the clinician know the patient had cancelled, ask for a date, and then ring the patient back. Then they might not be able to do that date, so you'd have to ring again. And that, as you can imagine, was very tedious and take a lot of time. But now that we've implemented some more standards, the clinicians are happy for us just to rebook it there and then whilst we have that patient on the phone. So it just really saves that backwards and forwards. We also agreed to come up with some standard comments from PAS. So we have a lot of waiting list comments that maybe we don't always understand. So that may mean that we miss doing a certain action. So in the week, we did a set of like what standards could be just throughout the whole service, so that it were really clear by that comment what needed doing, so the admin team could work independently rather than needing instruction or needing to ask for clearer communication. Next slide, please. I think the order in the green bin, I think these just follow what I already talked about. We also we are making videos on how to understand the reports in the informatic report suite. Obviously, a lot of what we do in the background, the business managers and the service managers, is track these reports and ensure things are moving along. But the clinicians have shown a real interest in wanting to understand these reports themselves. So we're making a video on how for them to check everything as well. So yeah, thank you. Next slide, please. I think it just says thank you. So yeah, I just want to thank all of the clinicians and everyone really for just being really open-minded. And we have a third one booked in for September. So more to come.
Brilliant. Thanks, Lauren. It's great to see the methodology being used and just how many things you can identify that are going to lean out and make it an improved process for everybody involved. It's those little frustrations that just drive people nuts, isn't it? And just to be able to deal with them so effectively, that's fantastic. Again, just conscious of time. I haven't seen April on the list, but I think we've got Elizabeth and Misbah. So can I hand over to you, please?
Hi, good afternoon. So we came to the QI crew last year in June. We came to present our QI crew that we started. So just to give a bit of background, so it was an opportunity to give our staff to get involved with QI and the methodology, and they were coming up with all these amazing ideas. We wanted to give them a platform, So we've just got a video to share from the preterm midwife. So we've got Lizzie here, just of one of the success stories from the crew.
Hi, I'm Lizzie.
And I'm Gemma, and we're both midwives in the preterm prevention team at Leeds. We've been in post now for just over a year, and despite having lots of experience in the hospital, community and specialist team settings, we had very limited experience of doing any quality improvement work.
So coming into the new role, we knew that there were different areas that we wanted to improve on, but we had limited understanding of what quality improvement was. So we knew that that meant making service changes, but we just didn't know how to implement it in the correct way.
Very early on in our new roles, we were introduced to April, and she explained quality improvement from a very basic level because of our limited knowledge and understanding. She explained the process that we needed to go through to achieve a successful quality improvement project, and she also explained to us the documentation needed to support the changes.
So once we had a better understanding of how to implement a quality improvement project, we managed to break our ideas down into different sections and then create the right paperwork for this. And then once we'd done this, we could then implement the project into practice. Then we took it to the QI crew, and we had a really positive and supportive meeting about all of our ideas. We discussed the projects that we were doing, we looked at the progress we've made, and then we had a discussion about different changes and ideas that we could do going forward. The quality improvement team have been really supportive of everything we've done so far, and they're also supporting us with future projects as well. So over the last year, we've launched 3 main quality improvement projects, one of which is STI screening for women aged under 25. So we know that chlamydia and gonorrhea are both more prevalent in women aged under 25, and we also know that positive cases of these are risk factors for preterm birth. When we looked at the compliance of screening at booking, in January 22 it was only 4%, so we realised that this was an area that we could definitely make improvements on. So using the quality improvement documentation, we created a driver diagram which helped us look at the drivers for change and our main aims. We also made a project charter where it gave us an overview of our project and looked at potential different barriers. And then through writing this documentation out, we realised that one of the main things was in the antenatal screening guideline, there wasn't a clear section on STI screening like there was about all the other areas of screening we do at booking. So we made a change to the screening guideline, which went through the exact process of what to do and why we're doing it. And then we took these changes to the big breakfasts, we took it to Friday teaching, we've gone to the different community midwife meetings, and then when we re-audited at the end of 22, we realised the compliance had gone up to 75%, which is a massive improvement.
Another quality improvement project that we've been working on is the provision of antenatal care for women at high risk of preterm birth. So when we started our role, we found that women who were coming to preterm clinic who were at the highest risk, so those women who had Schrodke sutures or had been commenced on progesterone, were going back to their local community midwife for their routine care. However, these women had additional emotional needs, usually because they'd had mid-trimester losses or had really early babies before and therefore needed extra reassurance and time for appointments. Often these women were seen at 16 weeks and then again at 28 weeks because they were on a multi pathway, but usually in that time frame that would be when they'd had previous losses or preterm births. So through the process of documentation, same as the STI screening, we looked at the process and we used a method of using a Jamboard to also look at where we were currently and where we'd like to be when we'd made the quality improvement changes to support the quality improvement project. And now we are providing extra appointments for women, longer appointments. We've got a midwife-led clinic which runs alongside the consultant-led clinic, and it's been fully established now for nearly a year. The feedback from the women is very positive, and as a team we're working together to improve the care of these women. This year we've also launched some new exciting quality improvement projects, and the QI crew are supporting us in those. Top tips for starting your QI projects: if you see something in practice where you think we could improve practice, be bold, make a start, speak to the QI crew about a potential project, and they'll support you along the way.
I would say my top tip for starting a quality improvement project would be to really take your time. I know that when you start a quality improvement project and you find something that you want to change, it's really easy to just jump straight in, but the most important thing is to take a step back and think about how your project could impact practice, and then write everything down really clearly, think about it from different points of view, and then start slowly, because then you'll be able to make the change bigger.
Oh, that's fantastic. Miss Barr, Elizabeth, do you want to come in at the end of that?
Hi, I'm Lizzie. I'm one of the preterm midwives, obviously from the video. I don't know how you wanted to round that up, Miss Barr. I think I've said everything in the video.
Yeah, I think this is just it just shows how the support in the crew. We've got governance, we've got business, we've got digital, we've got public health, and we all work together to support the clinicians on the shop floor. And I think this is just one of the projects. I remember the first time Lizzie came to the crew and they had no idea, so we helped support getting that baseline data. And I think this is another example of data-driven quality improvement, because we were able to evidence that data as well. So we've got about 20 projects in flight now. So
20.
We've got loads. Yeah.
Wow. That's fantastic. I mean, great seeing a great presentation, and a few other people have commented about some great tips at the end. I like, be bold, make a start, and then reflect on how you can make the change bigger. Mm-hmm. I mean, it's one of the things I talk about with my team in digital. We've got 22,000 staff here, so you need to think about how you can do things at scale when you're working for Leeds Teaching Hospital. And just doing little things is great, but doing little things that have a big impact is even better. So that's wonderful. I probably got time for a question or two on any of the amazing presentations we've seen today. If anybody's got anything that they'd like to raise, or that they've included in the chat and want to bring forward. I've put everyone off, haven't I, by saying you're not allowed to ask questions. Jenny?
Well, I did put it in the chat. It was for Tim, really. All three were brilliant, absolutely brilliant. So I have been adding comments as we go. But we did, because we were doing Summer Connecting, we did a really light launch on the Leadership Fundamentals Toolkit that exists in the organisation. It was really light. So just wanted to make sure that people on the call and Tim loved the concept of the lab in order to get people talking about leadership and practicing and building confidence. But there's loads for our people to connect with around CPD, both really formal and informal. And it's now all in one place in the Leadership Fundamentals. So I've put the link in the chat just so that colleagues can link in with it, really.
Right, thanks, Jenny. And Jimmy, do you want to sum up at the end of the meeting?
Yeah, thank you for closing statement. Just a thank you from me. Excuse me. Brilliant to hear the diversity, I think, of how people are using methodology, both core to the Leeds improvement method, but just having a go at improvements. I think the theme I'm going to take away is that have a go statement. All of these people have said, yeah, these stuff might be going for a while. There might be tedious problems, but let's have a go. And we've just heard what difference you can make by making a start. And I will reference back, I think, Lizzie's great point about have a go, but don't dive in blind. Have a look at it, take that step back, work out what your aim is. What do you really want to achieve with this stuff? And then get stuck in with the right people and bring them with you. So, yeah, that's what I want to add. Thanks, everyone, for a really inspiring half hour.
Yes, brilliant. Yeah, thanks to our presenters. Thanks for you for attending. And we'll be back here next week. And I think Phil will be chairing then. So thanks, everyone. Hope I didn't do too bad a job.